contact Deb or me. Anything right now? Okay, we are a little behind schedule. I apologize, Roger, but I will turn it over to you, and I'm sure you'll catch us up.
We'll catch up. Again, I'm Roger Shortman. I'm part of the CCMI CSI consulting team for this moment.
Roger, sorry, can you please turn your mic on?
Again, Roger Shortman, part of the consulting team supporting this effort. A very tough act to follow on those two presentations. You know, when you look at the amount of work that's going on here as part of this accountable community, all of you are working on your individual change plans and your quality improvement efforts. So there's a tremendous amount of just organic work going on in improving quality. And then you look at the shared work that you're doing. Diversions that we just saw, what the impact can be on the people you're serving, and what the Pathway Hub can do in terms of leveraging resources. It's really, really extraordinary to think about it. Our role as consultants is to help you build capacity and accelerate your execution strategies. And so as part of what we've been doing is a series of leadership modules over time, just reminding all of us as leaders, those that are supporting the organization, part of our roles and things to be thinking about. And today I'm going to talk about sustainability. If you're thinking about all the capacity building going on, whether it's motivational interviewing, empanelment, diversions, all the other activities, the Pathway Hub, whatever it is, all of that work has to be able to be sustained. I've working with a group in the Midwest that implemented a 340B pharmacy program. And it's a very powerful program to help people on Medicaid get discounted drugs. Many of you have 340B, some of you do. And this organization went out and did all of the classic things to engage their providers and staff to participate and give patients access to this. They have the pharmacies on site to send the people. And they are having a 70% leakage of patients leaving the property, going elsewhere to get their drugs at higher expense. It's $75 million to this system in terms of the lost revenue by not capturing those patients. And all of it is lack of building the reliable systems in their organization to get people to connect them to their own pharmacy on site in their own clinic. And so that's what this is really all about. Why are we so challenged in making things stick? I just recently implemented a change in a project management software in my own company. And it's been up and running for probably 7 or 8 months. And I had one of my managers coming and saying, we got to get rid of it. It's not working. You know, it's just too much of a burden, blah, blah, blah. And as we got to go into it, I immediately saw some of the failures in the reliability that we had not built in. So this is stuff that is somewhat common sense. But as Mark Twain said, common sense is that sense rarely commonly applied. All right, so this is a reminder for those of you that have really strong systems to ensure the scalability and reliability. I ask you to jump in and help with this. So this is a light slide that's a little bit tough to read by Edgar Dale. But the intent of this, and this is somewhat of an old slide, and more recently people are challenging the data here. But what it suggested is that when you hear something, you retain about 10% of it 2 weeks later. And as you move down the scale of when you read 10%, if you hear it 20%, if you're looking at pictures, a graphical image, it's about 30% retention rate, and all the way down to where if you say it and do it, you have a much higher retention rate. About 90%, 2 weeks later, you remember. So for those of you that have participated in any of the lands or the sprints, at the end of each module, we ask for some activity to go back in the field to apply the concepts that were taught in the session so that you're actually doing. And that moves you farther into that retention stage and less than if we send things out. Now in organizations, we do town hall meetings, we send out emails, we send out memos, we send information out and say, go do it. And that's why we have 70% leakage in our pharmacy return rate. We don't get it down to how do we get people to actually adopt what we're trying to change. So there's some sustainability principles. If we're making a change, making sure that the new workflow, what we're expecting people to do is crystal clear, that we have that mapped out so people can really understand. Secondly, we have to answer the question, or what are the roles of each of the people in the flow? Are they very clear on what their role is in the handoff, when and how that has to take place? Do we have clear policies that are going to lead to the sustainability of whatever change that we're making? Whether it's the 340B or the pathway hubs or whatever it is, this is the pathway, this is what we want you to do, this is our policy to support it. Are the training systems in place to help scale it? What's the training packet to go to each clinic, to go to each provider team, to go to each piece on how to make sure that that sustains? Do we have the reinforcement to constantly bring that in? How is it tied into our management meetings? How is it tied into our town hall? The communication systems, what we publish in our newspapers, what we publish on our bulletin boards, all of the reinforcement systems that make this the new way of doing things. Do we have measures of performance and reliability of the system over time? Is there someone responsible for seeing this thing through and owning it long term? What we tend to do is start a project, take it to a certain point, send out the emails, and they go, boy, that worked, what a victory. And then 9 months later, we're coming back with someone saying, this thing isn't working, we got to start all over again. So who owns it? Who is established as the owner of that process and can track it? And then how are we doing the audits periodically to make sure that it's working? What's that quality assurance, quality control function to see that it's actually doing what it's supposed to be doing? For those of you that are in environments with strong accreditation, Joint Commission and some of the other accrediting bodies, they're really high in reliability principles, building in these concepts of reliability theory. There's a series of techniques and tools around reliability, some of them just previously mentioned, but really having standardized processes in place, using reminders that are very conspicuous, contiguous, contextual, that are quick reminders that get people's attention, making the desired action a default. I had an organization I worked with that put in a new form on a floor. They wanted to keep the old form in place for a while, just so that in case some people were having some trouble with it. Guaranteed prescription for failure. You have to make that the new way, not an option of keeping the old way as a way to go. Where possible, replacing opt-in with opt-out. If you have to have a voluntary action to get in, it's much more difficult to get the masses to do that. If they're all included, much easier than the other pathway. Obviously, reducing the complexity. A lot of times you roll out programs and they're so complex, the information we're sending is just overwhelming, people just turn it off. So trying to reduce the complexity as much as possible. Making failure difficult and smoothing the workflow. An example of another concept of forcing functions. Make it the way that has to be done. Make it difficult to fail. Many of you have experienced the change in ATM machines. In the old days, you go to an ATM machine, you put your card in, and then money would come out, and then most people would walk away and leave the card in the machine. And so they now have reversed the flow. So in order to get your money, you have to take your card out, and then the money comes out of the machine. So that's a forcing function. It forces you to go into that pathway. They'll be thinking from a design perspective, how can we create it so that's the natural pathway for people to be able to do their work? And then promoting clear communication. So here's an example of some of the tools. This is an example of a top half of a policy, but as you see the bottom half of the policy, it starts to spell out a little bit more visually and by category. Here are the roles of people in that policy. So we have these policy and procedure manuals that are 11 to 13 volumes out there for our staff, and they're like, oh my, who's going to read all that, right? But if you can have a very quick cheat sheet that explains specifically what are the roles, when, and how people are supposed to do it, then much higher compliance. And then this organization took it a step further and developed the process flow that's very visual. And these process flows are what are posted on the walls and in the work units. So if you have a new employee coming in, it's not go read the policy manual over there. It's look at the wall right there. This is the flow for this particular piece. So you can see right away what the pathway is. And this is a group in Colorado that developed what's called a swim lane diagram, for those that haven't seen something like this, where each of the roles are spelled out. On the top, they have the core measures that they're tracking for this diabetes care. On the left-hand side are the individual roles, and then they have the actions that need to be taken by each member of the staff for that kind of flow. So those kind of tools help build the reliability. It helped build the opportunity for it to be reinforced in the environment. Use of visual controls. This, again, a lot of shadow boards, labeling bins, making things very crystal clear in terms of the new workflow, so that there's no opportunity, no confusion in the process. And there's some examples of starting to see increased tools being visual on the wall. Some of these are data tools providing feedback. Some of them are workflows that are explaining how to do things. Some of them are the color charts showing the pathway. And increasingly, these are moving to electronic formats. Starting to see much more often electronic boards in organizations where you can constantly be updating and changing those visual controls and tools and embedding them. There's actually a company called DIRT that makes modular walls and construction, and they've now embedded in their walls this kind of technology so that you can be constantly updating and communicating and doing visual controls in the workroom, in the exam room, or wherever it may be. So let me just stop there and see about comments or questions or any examples from others on how to ensure some of this sustainability of and reliability of new changes that you're making. Any questions or any examples?
Implementing a monthly QA meeting that follows up with PDSAs on our intake process, our nurse case management, and we're using that on a monthly basis to review the progress, and that's been really helpful.
So Chris is talking about a monthly meeting where they review the different changes, PDSA cycles, and then they talk about many of these things in terms of how do we ensure that they're happening. We're reviewing the data, make sure that it's following on. Yeah. Was that Sheila I heard on the phone?
Yeah, it was. Roger, can you go back to that slide that showed the process of learning?
The methodology, yep, the cone of learning, yes.
Okay, so talk me through that just a little bit more, because I want to use this leadership in our clinic, because we do so much of the sharing one time and hoping for sustained change. So just go over this a little bit.
Sure. This is a body of work that comes from adult learning theory. How do we learn as adults? And a lot of work going on now, since so much learning is through the web. It's changing our learning habits and the way we absorb and process information. But this basically walks through from the very top. You'll see on the right-hand side, there's passive learning and then there's active learning. And passive learning starts with reading. So if you look 2 weeks out, you retain about 10% of what you read. If you hear the words, about 20%, and if you see it, about 30%. I've had several children with learning disabilities, and one of my children, one of my sons, has to write out in class when he was hearing. They had to actually write continuously, and if you wrote it, he retained it. If he didn't read it, he had an auditory processing and couldn't absorb it. I have another son, interestingly enough, who we think has a photographic memory. And the other day, he was studying for a real estate test. And I saw him, and he was reading, highlighting it, and then writing it down, and then he said it out loud. And as I was preparing for this thing, oh my gosh, this is exactly the adult learning theory. He's actually translating it into the ways that he can retain. And here I thought he had a photographic memory, but it's these basic process. 50% is when you see something, so this is why we like visual controls, those kind of reminders. 70% of hearing, and then 90% of 70% when you say, and then 90% is when we actually say something and then do it. So this is the teach-back model in clinical medicine and in other environments. If you tell something to a patient and then they walk away saying, I don't remember what the doctor said, but if you ask the patient, okay, what's your plan? Can you repeat what we said here, and what are you going to do about it? Then the patient suddenly goes, can you remind me, or let's talk about it again. And then they, okay, tell me what you're going to do, and that way they retain the concepts. Does that help, Sheila?
Yeah, it really is. It just helps with that concept. Or what I continue to hear is, well, I told them.
And this is all a function. We are all so busy. There's so many competing priorities hitting us, so it forces us to get sloppy and not get disciplined in terms of thinking about things and packaging the right things as we move on.
Right.
Audrey, can I say? This is another reason why we have homework on learning activities, so that you can actually do what was being taught.
Exactly. Any other questions or comments or other examples? Yes, ma'am.
That turnover effect on sustainability is huge.
Absolutely. So if you're having somewhere between 12 and 30% turnover, depending on the organizations, in the long-term care industry, it's up to 70% turnover of staff in some of the facilities. If you have that, if you don't have those kind of visual controls and systems in place, you are just building in poor quality. There just isn't the time to train and do everything you need to do. So really paying attention to those core principles is critical in a high turnover environment.
I might add, sometimes it's helpful if you're doing a dramatic change, moving from one system to another. Sometimes having an event where you sort of like have almost like a funeral or something for the old system, but it really kind of something that really marks the changeover, I found is a pretty good way to kind of push people to doing something different and accept it. So kind of have that ending zone.
Great observation.
Missed our chance for
Mr. Chen, for Avatar. All right, with that, let's transition. And what we wanted to do is talk forward now in terms of the work ahead. I think it was David Olson at the last meeting said, where did some of these things that we're working on come from? Some of the topics and how are we going about this? Just to create a break and trail back, it was about a year ago that we were all together and had a full day planning session. And at that planning session, you brainstormed a list of topics and core competencies that you wanted to work on. Those core competencies were the basis of the work we've been doing up until now. So integration of behavioral health into primary care, primary care into behavioral health were some of the top areas that you talked about last year. Motivational interviewing was other topics, and basics and quality improvement training. So that has all been acting out up until this time. We had several learning and action networks, one on helping you all develop your change plans. You're now implementing your change plans, and you're about to do a second cycle of reporting on your change plan. So that's now going to give us...
it done by now, you're in trouble.
Yeah. So you're... So we're now going to have some data to start to see 2 data points of what's happening in the environment. What are you working on, and where's the effort and energy going? So we've been trying to plan over the next 6 months to a year. Where can we be most helpful to you? What are your greatest priorities? And we've talked over the last couple of months about some of the data, looked at some of the state data. We've talked about asthma, whether it was a high priority, not a high priority. Had some discussions about other topics. And then we just most recently did a survey. So with the survey, we wanted to present the results back to you of what we heard. And so if you look at one of the first issues was to please rank potential topics for learning activities in order of priority for your organization. And you'll see optimizing care teams was the highest priority. That came back just in terms of frequency distribution. So left-hand column, the y-axis are the number of respondents that rank that. And so access and behavioral health, population health, we're second. And then you see access is a close third in terms of third or fourth in terms of topics. So this is just a first cut of what you relayed are some of the most important things to you. And certainly this is informing how we see and would recommend things moving forward. There are a lot of other topics that were suggested. Gathering data through conversations and how to encourage patient storytelling was a topic. Data extraction for measurement and reporting. Integrating treatment plans to include both behavioral and physical health, and teaching behavioral health clinicians how to address physical health coaching. Successful outreach techniques and strategies. Billing, coding, and reimbursement for critical access hospitals and RHC facilities. Generating revenue, denials management, prior authorizations. So those are some other topics. Many of these might lend themselves to one of events, a webcast, or a short 1 or 2 webcast series. For example, coding, that might be something that could be done in a couple of sessions. So we're going to be exploring some of those one-of opportunities to help meet some of these needs. Please rank the following content areas in order of priority for your organization. So this is where we had that wonderful asthma debate going back and forth, and what are the data and how much of a priority is it? So what we heard was actually diabetes and depression were your two top priorities. So if you're going to work on clinical conditions, those would be the highest yield across the environment, the greatest opportunities for collaboration, if you would, in the environment. Other conditions, lots of other conditions, preemie care, failure to thrive, and autism evaluations, chemical dependency, lack of mental health resources in our area. Outside the obvious mental health conditions, interested in obesity as it relates to a variety of physical health conditions, trauma, COPD, colorectal cancer screening, obesity, dementia, heart failure, and sepsis. Again, some of these might be able to be dealt with in individual topic series for those interested. May not need a formal learning event, if you will. So we'll be exploring how to meet some of these needs through that mechanism. So one of the questions is how to best convene people. We are very cognizant of the amount of time it takes for people to travel, for people to participate, and to balance between face-to-face and virtual opportunities. A lot of the face-to-face opportunity moves you down also in that scale in terms of engaging others in that dialogue and acting rather than just watching a television show on the screen. So that balancing act. So we wanted to find out what's your appetite. And so what we heard is basically a high degree of interest and support on the face-to-face meetings that they, with peer organizations, we would find the benefit. Obviously, there are caveats. They have to be value-added and substantive. We don't want to just get together for the sake of getting together. But face-to-face is a valued activity. We talked about some of the requirements, and there's an annual face-to-face meetings or virtual meetings or an expectation of the WPCC. Would you be willing to attend more face-to-face meetings in a year? So this is helping us calibrate. Would we have the ability to get together more often to do some substantive learning? And what we heard is yes, people would be willing, with a caveat that again the right topics and it's value added. And we would be willing to send more people than just having one person attend. That would benefit our organization. How many team members would you be willing to send? And so we got some data back saying it depends on the topic and what the issues are, but we would be willing to send, again, more people. So translating all of this into work planning, the planning is ongoing, and so we wanted to test an idea with you, and then we'll continue to refine and come back. We'd like to pause any final design decisions until you all get the data back and see where your priorities are and what you're working on and how things are going with your own change plans. But clearly working on team-based care and how to optimize that care team is a hot topic that we've heard, and we'd like to launch a LAN in the near term addressing that specific issue. And that has the opportunity to potentially transcend both behavioral health and the primary care and other care environments. So that is something that we are in the planning stage, and we'll be looking to launch that potentially in the near future. Again, none of this is final. We're asking for you to design this, not just drop it on you. But what we would like to suggest is a model where we could broaden the learning experience but reduce what we proposed last month in terms of the number of tracks and specific work groups or sprints or other activities that you would be asked to participate in. And what the basic model would propose is that we would have a learning session, a face-to-face learning session that would be held more likely in the fall, that would be addressing at a very high level population health, and then many of the things that you identified as those priorities. That would include some of the access pieces of it, some of the care team component pieces, and some of the chronic disease management pieces of it. And in that would be face-to-face. The model would be combining both plenary and then individual breakout opportunities on focused areas that would hopefully resonate based on the feedback that you've been provided. So we would come back with a design on this. And then work over the course of the year with a virtual learning session later in the year, in the December timeframe, This would be a half day, afternoon, morning type of format. Again, on very focused, specific topics with the potential of breakouts within that learning session. And then in 2020, to have another learning session in the first quarter. And this basically follows a quarterly pacing, if you will. Then a virtual learning session, and then another face-to-face later next summer. What the commitment would be is that we would be asking you to have a care team participate in the learning opportunity. And so this would be what you would identify as the core group that is taking care of a panel of patients that would be able to benefit from the learning and could be the prototype of your organization to be able to take that and be the champions to help spread the learning through your organizations. What we'd be asking is a monthly all-team call during these, in between these quarterly sessions, and these quarterly gatherings, as we talked about it, and then care teams working on a common set of measures based on those high priority tracks, depression, diabetes, if those are the ones that ultimately end up in the activity. Where possible, we would want this to align with your already existing quality improvement efforts. So if you're already having projects based on something you're doing for external accredited bodies or for your internal purposes, that this aligns and that this is all part of an aligned improvement effort. So that's the broad concept. It backs off on a lot of weekly pacing and other activities, moves it to a monthly cycle. The organizations, you would be moving at your own pace, working, but you would be benefiting from the broader subject matter experts. We would be bringing, based on the topics, external subject matter experts from the region and from your organizations, and then nationally, depending upon the topic and what we would be working on. This would be augmented in the background with the practice coaches that are working with your organizations and your own internal quality improvement efforts to accelerate your work. All of this hopefully tied to the core measures that are in your change plan lands and that what you're tracking to the HCA, so that you're helping to move those needles. And then we would use this body to continue to self-adjust the learning model over the course of the year. So you would be providing feedback from your teams and helping to provide input to the design as it rolls out and we move forward. So that's the concept of where we are now. It is not a baked cake. It's a lot of ingredients with concepts that we're trying to calibrate whether this is in the right track. And if so, what we'd hope to do is at the May meeting, review the data from your input into the system and talk about that in that context. And then, so what? If this is where you are with your data, then how can we help you accelerate your work moving forward? The individual learning opportunities, quality, motivational interviewing, those things will continue based on your demand, need. So if you have that need, we'll continue to be offering those. And again, the question about turnover, I think, is relative in that context. So questions and comments. Wendy, did I miss anything? Or anybody else on the phone that would like to comment or ask a question?
The only thing I want to mention is we did hear you in the survey is that you cannot participate in more than one learning activity at a time. We had proposed it, and we did hear loud and clear that one learning activity at a time.
So this would be one learning activity of which you would choose what you want to really focus on within that learning opportunity, but you're going to be benefiting from the content in the broader sense. Comments? Chris over here has got a thumb up.
I think it sounds like a great plan from the Moses Lake perspective, timely for what we're trying to work on.
It's got 3, 4 thumbs up. So enough positive feedback that we could try to gauge here. I'm going to use some motivational interviewing techniques here. So enough that we can proceed with the planning then and come back to you with a little bit more baked and the depth in terms of what the content and approach would be. Is that, you would welcome that potentially the next meeting? Okay. So that's what we'll do.
I will say that we are trying to plan that first face-to-face to coincide with the symposium that we had already planned for the year. So we're not asking for an additional one. That maybe it will be that the symposium will be the kickoff to this whole thing. And so we're working together to see how we can do it and leverage the time we have already in the MOUs so that we can be respectful of your time as well.
So trying to align this with the commitments that you already have in place and not add, and try to add as much value in terms of the topics that you're telling us that you want to work on.
This is Shoshana Palmatier from Cooley Medical Center. I have a quick comment on this. This sounds like an awesome learning activity, and we really like to participate. I think the main thing that we would appreciate is maybe just some input on dates of the meetings, especially for provider care teams, just to make sure that they're available.
And we'd like to be able to map this out for a year so that you know ahead of time what the expectations are and you aren't scrambling to work on that. Thank you for that feedback. Any other comments or questions? All right, Wendy, I'll turn it back over.
Thanks, Roger.
Thanks, Roger. I look forward to really getting this kicked off so we're not keep coming back to you. Just so you know, we did present that learning activity schedule back in December. This is not necessarily replacing that. We're just organizing the pieces in a better way so that it better meets your needs. So the content is basically the same. The way we talked about it once is the way we originally presented it. The puzzle pieces were laid out on the table, and now we're putting the puzzle together. So it's basically the same thing if you look at the content. We are getting to some content specific, topic specific. But the general thread is we're not switching course, we're just adapting it based on the needs we've heard within the group. Any questions? So we are back on track. Thank you for talking fast and getting us back on track. 4 minutes. Does anyone have anything they would like to share in the last 4 minutes that we have? Good work that's going on? Time to brag about your organizations or your employees in your organizations, programs? Did everyone see Loretta's TV debut on Drug Court?
Yes.
I will send that out.
Oh, that'd be awesome.
It's nice. She did a.
Get her signature.
Go ahead,
now.
Loretta.
Or she can say that she doesn't know any of us.
Go ahead.
It was just, it was a little piece on drug court, and it involved the entire team. It wasn't just me. It had the judge and the prosecutor's office, public defender's office, and then treatment. So just kind of the real stars of the show were the 2 patients that from drug court that were interviewed and talked about their experience and how different it was to be in court and have positive feedback, positive experiences, and how they felt like that the team was wrapping around them and actually looking at their needs and what they needed to do to be successful. And some of that was really creative around transportation. One gentleman had a health condition that he hadn't looked into, but had really been bothering him for a number of years. And so that was one of the judge's requirements of him, was that he go to the doc, get that checked out, and bring that back and report on that in the next 2 weeks. And turned out to be absolutely nothing. And so that was a positive experience for him. Visiting with children, and someone moved into an apartment, and so a group gathered some things to be able to give to him to be able to put into his apartment. He'd never had one, young 30-something-year-old, and never had an apartment on his own. So one of his highlights was he realized that a shower curtain is a really good thing, something that he hadn't thought of. So, just being able to have that experience with him, it's really a highlight.
Greta?
Wendy, can I say something?
Sure.
Catholic Charities is going through a reorganization.
Do you have your mic on?
Hi, this is Chris Devalnu. Catholic Charities is going through a reorganization process. Chris Davis is taking a new position, has resigned from Catholic Charities. Susan Marney is now our interim director, and we're doing a lot of work on some changes within the agency, and we'll send out information on that soon.
Thank you.
It wasn't an April Fool's joke.
Anything else? Okay, last two announcements. Don't forget the VBP rural multi-payer model discussion happens in this room at 1 o'clock, starting at 1 o'clock, and the annual